Okay. Can you wait?
Awesome.
All right. I think that's good.
Yeah, we can hear you loud and clear.
Okay, good.
All right, so we'll start. I'll start with all the introductions, and we'll continue with the webinar proper. Hello, everyone. You're welcome to this webinar that is organized by African Women Cancer Association, Awareness Association, and African Women's Cancer Awareness Association was founded in 2004 as a nonprofit organization in the National Capital Region. And our mission is to develop solid partnerships that work together to reduce the existing disparities in awareness, education, prevention, treatment, and care of breast cancer amongst African immigrant women, especially the medically underserved and underprivileged. We do this through education and awareness outreaches, as well as personalized professional navigation services for screening, diagnosis, and treatment of breast cancer amongst African immigrant communities. And over the period of 16 years, AWCA has also expanded to reach out to the African American communities. And that is why we are actually doing this webinar today that cuts across not just African immigrant communities, but also the African American communities. And today we'll be discussing the impact of COVID-19 on people living with breast cancer amongst African immigrant communities and African American communities. And we have Dr. Kim Johnson. Dr. Kim Johnson is the Senior Director of African American Health Equity Initiative at the Susan G. Komen Foundation. And Kim has quite a lot of experience in health equity and breast cancer. So Kim Johnson is a senior director, like I said, and the goal of the initiative is to reduce disparities in breast cancer outcomes within the African American community by 25%, starting in the 10 US cities where the inequities are greatest, including Memphis, St. Louis, Atlanta, Chicago, Houston, Washington, D.C., Tidewater, Los Angeles, Philadelphia, and Dallas, Fort Worth. Dr. Kim brings more than 20 years of experience directing national health equity programs to improve the capacity of healthcare providers and community-based organizations to provide culturally competent prevention and treatment services to improve health outcomes to communities of color. Prior to joining Komen, Dr. Johnson served as the principal investigator and director at the National Minority AIDS Council, where she led capacity building programs to improve health equity within communities of color nationwide. She has dedicated her career in healthcare and public health to effectively improve health outcomes of persons disproportionately impacted by disease by working to improve access to care and quality of care. Since earning her bachelor's degree from the University of Virginia and doctorate degree from the Medical College of Virginia School of Medicine, Dr. Johnson completed a family medicine residency at the Pitt County Memorial Hospital in Greenville, where she specialized in minority health and women's health. She has served as healthcare consultant to several agencies within the US Department of Health and Human Services, where she is recognized for developing high quality, evidence-based public health programs targeting communities of color and resource constrained population. You're welcome, Dr. Kim.
Thank you so much, Chris. I didn't know you did the whole thing, but
yeah, so what an intimidating bio here.
I was hoping you would just shorten, just take a note.
Well,
Thank you.
it's important that we read this so we know the caliber of resource that we have at hand, so that everyone can actually maximize the information that you'll be sharing with us. So we are glad to have you here. AWC is glad to have you here, and I believe that everyone watching is keen to learn something from you today. So we're going to start with the first question that has to do with your current work. So just tell us about the work that you do through the African American Health Equity Initiative at Susan G. Komen.
Sure, I'm happy to. First of all, I want to thank you and the organization for inviting me. It's really an honor and a pleasure to be here today. And I know we have abbreviated time, so I'll keep some of these brief so we can get everything in. But the program, as you mentioned in my bio, is called the African American Health Equity Initiative. And the work we're doing is really about decreasing disparities in the Black community by 25% for breast cancer. And we're starting in the United States metropolitan areas where those disparities and equities are greatest. I won't read the list of cities because you already did in my introduction, but what we're doing is taking an approach called collective impact, where we're engaging communities in these large metropolitan areas to work together to offer services to the Black community that hopefully will decrease disparities. The main services we're providing after conducting a large landscape analysis is going to be patient navigation services. And that is so integral to the project in this work because it helps to improve recruitment and retention and engagement of the Black community, both in breast cancer screening, care, and treatment. But also for this project, I'm committed to increasing the number of Black patient navigators who are in our current workforce in those metropolitan areas. That way we can be assured that we have culturally intelligent navigators who are from the Black community working in and with the Black community. Also, we're offering through the project, or will offer, genetic counseling and testing services. And so, as you know, many in the Black community, many women are high risk for breast cancer. And sometimes they don't know exactly how high of a risk they are in terms of contracting this illness. And so what genetic counseling and testing does, it increases a person's knowledge about their breast cancer risk. Doing this type of intervention hopefully will empower, if not at least educate, Black women and Black families to know their risk and to seek the care that's necessary and to make informed healthcare decisions around their breast cancer care. And finally, which is not finally, there's a lot to this project, but I picked three. We're really looking at improving quality of treatment for breast cancer in this community. We know that in oncology overall, one of the drivers of disparities in oncology, period, including breast cancer, is the disparity in the quality of treatment or oncology treatment that patients get, especially those in the Black community. And so we're very committed to improving quality and leveling this playing field in the treatment arena for Blacks. So we're partnering with the American Society for Clinical Oncology that really does work to improve quality of treatment. They're going to administer their Quality Oncology Practice Initiative in our 10 metropolitan areas. And so in clinical practices in those 10 cities, we have selected with them 10 practices that work with the Black community to improve the quality of treatment for Blacks in those cities. So that's essentially, the main things we're doing in the initiative. All of the things I'm looking at are really what's very important. This is a public health initiative, and I'm very committed to offering sound public health evidence-based interventions that are been shown and proven over time in the years to decrease disparities.
Wow, that's a lot of work that you have out there. So I would want to know how much impact have you been able to make since the inception of this project?
So I came to Komen this time in 2018. So I've just been here coming on 2 years. And one of the commitments I have to the project in terms of making an impact really comes from maybe both my background in healthcare, but my background spiritually is really wanting to meet the people where they have the need, and meeting people where they are is so important. Not just assuming you know what people need because you might have studied it in school, or you might, have read it in studies and articles, but I bring a commitment to meeting people where they are. So in order to do that, and in order to make the greatest impact with these interventions, we're conducting a very large, detailed landscape analysis or community health needs assessment in each of these large 10 cities. And so we're really looking at some of the, trying to identify what are actually the drivers of the disparities in the 10 cities. And so we're working with the private contractor to gather this data to better understand what's the disease burden of breast cancer in each of our cities. What are the systemic barriers, and including adverse social determinants of health, socioeconomic barriers, as well as contextual factors that are really driving these inequities. We're exploring community members' perspectives. We're getting information and interviewing providers in each community. We're interviewing current patients with breast cancer. We're interviewing navigators. We're interviewing survivors. So we're really trying to take a broad stroke at looking at what are the individual and community and health systems factors that are really driving this in these cities. And we're also identifying and looking at what policies, both state and federal and local policies and environmental things that are actually helping to mitigate the disparities. So a lot of this work, I hope, will guide and improve our impact as we begin to launch interventions. So we've only started the quality improvement for treatment intervention. Our first training begins in January. Up and through now, we've been selecting practices and preparing them, and we're doing site assessments. And then all these other interventions will follow. But I've got to make sure that these interventions are the things that each community needs. And so what's going to work in Chicago may not work in Philadelphia, but it also may work in Atlanta, so things like that. So that's where the impact, I believe, will come in, is having laid a proper foundation and really understanding the needs of the cities, but meeting the Black people in those communities exactly where they are.
Amazing, amazing. So now, because you've just talked about community health needs assessment, and that actually brings me to the next question, and that would be, what has been the breast cancer situation like among, Black communities in the United States? Having seen that you guys have done quite a number of extensive assessments across these communities.
Yeah, and that's a good question. As you know, and maybe your listeners do too, breast cancer is the second leading cause of death among Black women in this country, and it's been that way for quite a long time. What we have seen in the Black community is, on average, African Americans, or Blacks actually in the United States, are 40% more likely to die of breast cancer than white people in our country. We as Black people are diagnosed at later stages of the disease of breast cancer. When we are diagnosed, we have more aggressive forms of cancer, and our treatments are very limited and very costly. And typically it's accompanied by a very poor prognosis. And so that's really the state of breast cancer in the Black community in our country. What we also have found, both from data we are collecting now and data we've collected in the past and others have researched, is that when you think about this landscape, and the landscape really is one of disparities and health disparities in this community. When I think about disparities in the Black community in terms of breast cancer, race and place really do matter. The data shows us that in certain areas of this country, there are higher rates of disparities, both in breast cancer, social determinants of health, socioeconomic status, and other things, than there are in other areas. And so, for instance, like when we look at our targeted metropolitan areas and we think about the disparities in breast cancer, one of our targeted cities, if you are a Black person living in one of our cities, and I won't name it just to be fair, but living in one of our 10 targeted cities and you're a Black woman, you are 74% more likely to die than if you were a white woman or if you lived somewhere else. And so unfortunately, the challenge we're seeing is a landscape riddled with disparities and inequities. And the problem too is that where you live and what color you are may actually determine whether you live. And that's the challenge, Chris, that we're facing.
This is actually a huge burden, especially for people of color. I can't imagine thinking that because of where I live or because of my skin color, I'm probably going to die before any other race, in the country. That is scary. That's really scary.
Extremely.
Now, so I would want to ask to find out what are the health disparities that exist among Black communities, and how is it affecting people living with breast cancer? Because we know that these disparities are huge. They exist. They are there. They are things that we experience every day. So what are these disparities?
Yeah, so to add on to what I've said earlier, there are disparities in just about every area of the social determinants of health, meaning there are disparities means difference, right? And so there are differences, but there are also inequities, meaning that there are differences that are preventable, but are caused by systemic issues. And so there are differences that are related solely to social justice issues in terms of racism. So typically what we're seeing across our 10 cities, and I would dare say across this country, but more apparent in these larger cities that we're targeting, is really disparities in the social determinants of health. There are differences between education levels, for instance, between Blacks and whites in these cities. There are differences in access to care and resources that are needed for healthcare. There are differences in how providers of Black patients treat their patients versus how they treat their white patients. There are differences in how your health insurance, depending on what plan you have under Obamacare, whatever plan we end up having in the future, there are differences in health insurance providers as to what providers will pay for what services. And sometimes what we're seeing is that sometimes some of those policies that cover more and would treat more and pay for more are more expensive. And many times they're not affordable in the Black communities. And so it results in having these insurance policies that are not created equal and they're not distributed equal. Those in this country, what we have seen is the haves continue to have and the have-nots continue to have not. And so if you pick any social determinant of health, any of those factors that really contribute to where we eat, learn, live, pray, and worship, all of those things, transportation, healthcare, education, political policies, systemic policies, all of that stuff in public health that's kind of upstream as we look at our continuum. Those where the disparities live for Blacks in our country. And what I'm saying is they're off the charts. They're more than the average city in our 10 cities. And that's across diseases. And so what we're looking at is a huge systemic problem in this country when it comes to how it cares for, how it treats, but also how it discriminates against Black persons.
The more you keep saying these things, the more we get enlightened, and we're seeing the dangers that are within the communities where we exist, and the high burden of disease that preventable diseases actually that we could have prevented, but then we can't because of these disparities that exist and these inequities that exist. And now looking at what is happening now, we have COVID-19, and COVID-19 has ravaged, quite a lot of things, both economically, both people's careers in terms of jobs, health-wise. We've seen quite a number of cases, quite a number of death cases, quite a number of, people are recovering, but then the impact of COVID-19 on everybody is high. But then let's talk about the people living with breast cancer. How has COVID-19 impacted people living with breast cancer?
Yeah, and that's a good question, and you're exactly right. This pandemic is acted like a pandemic in so many ways, in that it also discriminates, or what it just does is it highlights or amplifies the disparities that already exist in healthcare, have been amplified by COVID-19. And so the data is still out. There are some studies being done. We're only 6 months in or so for this pandemic, but initially what we're seeing in general in terms of overall is that we are seeing that more people are with breast cancer are dying, or with any type of cancer are dying of COVID at rates that seem to be higher than the general population. There's not enough data to justify all of that just yet as to why that would be so. But what I will say about breast cancer patients in this COVID-19 pandemic is that the challenge we're seeing for our patients is that the healthcare system still remains quite overburdened with caring for patients with COVID. It was more so at the beginning of the pandemic. In some areas, it's improving, and then some are spiking back up again. But because of the taxing nature of this pandemic on our healthcare system, what it's done is there are shortages in beds and protective equipment that have been noted before in the media we've seen. And in many cases, local governments and state governments are calling on doctors to actually delay elective surgeries in these areas. And so for the breast cancer patient, an elective surgery doesn't mean it's not a necessary surgery, and they still need to get their lumpectomies and other things like that. The elective surgery just means that it's not life-threatening. So what's happened is it's increased anxiety in the breast cancer community, because many of their surgeries that we would classify as elective, still important, still necessary, many of which have been delayed. There have been some delays in terms of accessing the care until things settle down in terms of the hospitals not having so many shortages and their physicians being able to see them in person. And so it's caused some anxiety among breast cancer patients who worry about, how is delaying my potential elective surgery going to determine or impact my chances for long-term survival. One thing I'll say, though, that is a silver lining, if there is one, to this pandemic, what it has done, though, is bolstered the healthcare community's ability and need to increase its telemedicine activities. Telemedicine has been in place even when I was in residency, and we won't say what year that was, but telemedicine has been around for a while. But because of the pandemic in healthcare, we've had to rely a lot more on telemedicine. So one of the remedies, you may not be able to have your surgery that's elective, not treatment, but elective, when you first had it scheduled. Breast cancer clinicians are working with their patients closely through telemedicine to ascertain, their symptomology and how they're feeling, even to address some of the anxiety that is existing in the community. So, there are pluses and minuses, but I'll tell you, this pandemic is impacting disease states across the board, breast cancer not excluded.
Wow. So now there's something about this COVID-19 and how it's actually impacting people living with breast cancer. Already we know that anyone who has or who's been diagnosed or who's living with breast cancer is immunocompromised, so there is that tendency that there could be complications that arise from COVID-19, as a result of their medical condition. And, that already is something that is disturbing because it's, apart from the disparities that tend to affect Black people, and to also for us to see that the chances of people who would be diagnosed to live as compared to the white community is actually lower. Now, adding COVID-19 is another, another situation to it, and that also is trying to still say that the chances of survival is getting slimmer, with COVID-19 coming up. So let's just see how we can address the issue of how people living with breast cancer can keep safe. Because if you know that there is COVID-19 out there, and you know that if affected, you stand a lesser chance as compared to someone whose immune system is really strong, there is that tendency to be extra careful. There's that tendency, or there's that need, for one to be extra careful. So what are the things people living with breast cancer, what should they do? How should they keep safe?
So we've been messaging and repeating, what the CDC has for guidelines for the entire population, understanding that while the breast cancer patient may be immunocompromised, especially if they're on chemotherapy regimen at the time, it's vitally important that they follow those CDC guidelines by following the social distancing guidelines that the CDC has put on their coronavirus.gov site, following, wearing the mask, limiting their outside and exposure to persons, kind of keeping that quarantine and obeying those guidelines is more than essential in this population. It's essential across the population. I will say that. I don't want to minimize that, because if everybody else doesn't do it and the breast cancer patients are the only ones doing it, that's not going to work. So we've really just been reiterating those CDC guidelines and driving that home for our clients in terms of those who have breast cancer, because we want them to have the best chance at survival that's possible.
Thank you, Kim. This is really very critical. I believe that this information by CDC has been going out there. Every organization, people have been putting out information about how to keep safe, what to do, wash your hands regularly, practice social distancing, stay away from crowd. If you have to go to use your face mask, have a hand sanitizer. If you have to go to the grocery, you live in the house, send one person to go to the grocery. And when the person comes back, the person should, have their bath and ensure that, they keep safe. And if you are feeling anything at all that looks like a sign or a symptom of COVID-19, make sure you put a call across. Isolate yourself, if you suspect that you've been exposed to someone who may have had COVID-19. This information is out there for everyone. Try as much as you can to keep to them, because this is how to stay safe. This is how to stay alive. We all have to stay alive and survive this pandemic, and this is the only way to do that. Kim, I'm going to ask you one other question. We know the health disparities that exist, generally in the country, and then there is now the disparities that exist as a result of COVID-19. How are they similar? How are both disparities similar?
I'm glad you asked, because they are similar. And I will tell you, it's similar across diseases, but it's especially similar to coronavirus. What this pandemic has done, it has amplified pre-existing inequities in the Black community in health in this country. So coronavirus, like breast cancer, has hit the Black community for decades. And well, the Black community has been hit for decades by breast cancer and other diseases, but now this decades of inequity is on full display. So one issue we have in terms of coronavirus is this: as they're tracking this pandemic across the country, there are only a few states, there are only some states that actually track the pandemic by race, meaning that they pull out the data and ask the question and document the question of what the person's race is. That's a problem. When you don't disaggregate your data by race, it's hard to tell then how this pandemic is affecting some populations versus other populations. But in states where the data of race is known, Blacks in this country account for more than 40% of COVID-related deaths, but we only represent a total of 13% of the United States population. If that's not a disparity, I don't know what is. What we're seeing too is the trends remain the same, that the cities with the racial disparities that are the greatest in breast cancer, those cities that you listed in my bio that have the greatest disparities in breast cancer, guess what? They have the greatest disparities in COVID deaths for Blacks as well. And so when I look at the 10 cities that we're targeting in my initiative, at least 7 of those cities account for more than 60% of the COVID deaths, and some of them account for 70% of the COVID deaths in this country. So the same rates that I'm seeing in breast cancer disparities in Blacks are quite similar to the rates that I'm seeing in COVID-19 deaths in the same places. So when I say, when it comes to disease in this country, your race and place absolutely matter. Who you are, the race and color of your skin, and where you live, unfortunately, can determine whether you live.
That is so sad. I would not want to end this webinar being sad. Okay, so we would try as much as we can to drive to certain solutions around this and see how even as Black people we would rise above, try as much as we can to rise above these disparities, and also to just make sure that we put out this conversation out there and advocate, for better health care, quality healthcare access, for people of color. So I'm interested to know, what are the drivers of these disparities?
Well, it's a lot of the things that we already know. The same drivers of disparities and other diseases are the drivers of this. The major driver in this country of breast cancer disparities, disparities in COVID-19, pick a disease, disparities in HIV for Blacks in this country is systemic racism. That is the key driver. And the individual racial bias that stems from that systemic racism are the key drivers, I would say the largest drivers. But also there's disparities in the treatment, the types of treatment, disparities in screening. There are things that cause these disparities, or disparities in access to care, appropriate health care. There are differences in our health literacy or our understanding of our disease if we have one. There's differences between Blacks and whites in this country. There are disparities in our genes. Genetics does play a role. It's still being studied in breast cancer, but we are finding that it does play a role for sure. There are disparities in clinical trial participation. If we had more Black people in clinical trials, when the drugs for these diseases are tested, we could show better efficacy for those drugs to treat those diseases. So if there were more diversity in clinical trials when they're creating and testing and approving drugs for breast cancer, meaning if there were more Black people who were a part of those trials, we would have a better foundation to know how do the drugs work in the Black population. That's a big one. Why is there problems with chemical trials? That's a whole nother webcast. but there definitely are disparities in that. Part of it is due to our cultural beliefs and or some mistrust of the healthcare system. I'm not blaming the Black community for that mistrust. That was propagated through inappropriate and egregious behavior by researchers in the past. We have a long history of that in our country. That's another webcast too. But I mean, we haven't forgotten. That's been passed down generationally. There's an inherent mistrust sometimes in the healthcare system. And so there is a lot of things that are the drivers of these disparities in breast cancer. And I would say a lot of those same drivers are drivers for COVID-19 as well.
Thank you very much for highlighting all of these disparities. Like you said, there are things that we experience every day. They are right there in our face. So we see them, we experience them, we live them. So I would want to end this on a very good note, in the sense that we have to think about strategies to addressing these disparities. So what could be the strategies that can be used, to address these disparities?
Yeah, and I'm glad you asked. I hate to be the bearer of bad news or paint such a grim picture, but really I'm just telling you the story that exists. But there is opportunity here for us to change this, but it does require commitment. It requires commitment from each one of us, regardless of who we are, regardless of what our race is, regardless of what positions we may hold, whether we feel it's one of influence or not. There is a role for each of us in this, in that we really do need to pick up and make a commitment to make these changes in racial health disparities in this country. And I would challenge our audience to not to just do this during a pandemic and then have this apathy that happens after and when this pandemic ends. Sometimes people will pick up a charge because they see the problem in their face right now, but actually then when that sort of seems to pass, we go back to the way we used to be. We really have to invest a long-term commitment across all the sectors in this country, in terms of government and healthcare, education, faith-based sectors, social service sectors, business and industry, all of that has to make a commitment to addressing these disparities, or else another wave of disease, another wave of illness is going to act the same way as breast cancer has acted in our community, and this, the same way COVID has. So we also need to commit to aiming our interventions not at the patient only, but also at the system. Pardon me. At the system too, we need to make systemic changes. It's gonna take a village, it's gonna take a country, it's gonna take all of us working across sectors, but being equally committed to really making these changes apply and to really making them stick in our country. We need to look at this problem as one of an intersectional nature, and we need intersectional solutions, meaning we need to address social determinants of health that drive these disparities as we address the disparities themselves and the conditions in healthcare themselves. And so I would finally say what we all can do is really find a place where we can commit to acting with compassion, being motivated by compassion. And compassion not only means you suffer alongside someone or you kind of relate to their suffering and have empathy, but it really means those feelings that you feel for that person and their cause prompts you to take action to really relieve the suffering of another person. So at the end of the day, like Martin Luther King said, our lives begin to end the day we become silent about the things that matter. give your voice to this. Give your voice to addressing racial health inequities, whether it be in breast cancer, in COVID-19, diabetes, HIV, pick a disease, anything that you feel that you could work towards. Give your voice to that cause. Your voice is more powerful than you think, and be motivated and moved by compassion to help someone who may be suffering alongside you. You'll never know on when that day would happen where it may impact your family. We hope it doesn't. But then hopefully changes will be in place in our healthcare system, changes will be in place in our public health system, and change will be in places in our nation if we could unify and commit to doing this.
Wow, it's been a long ride talking with you, Kim. Very enlightening, very empowering, very insightful. And I am really glad that we actually had these discussions because, one of the things that AWCA does is to also help to bridge that disparity gap amongst people of color. And that's why we do carry out all of the services that we carry out, through this organization and through the grants that are being, given, for this work. So we're really grateful that you found the time to do this with us and to just share some of the work that you do, some of the impact that has been made amongst our communities, and just to talk about COVID as well and how we can actually address, because people are experiencing these things, but they don't see the disparities that exist even in COVID, except someone is affected and they get to go to the hospital or try to access care, and then they begin to see all of those inequities that exist, So it's important that our communities begin to know these things, and people who are in positions of influence and people who, not just in position of influence, everybody can actually give their voice to say, what, we are working together. This is a systemic problem, and we cannot overcome this. We cannot rise above this if we don't collectively work together to ensure that these disparities have been taken care of. So thank you, Kim, for this amazing time with us. We really appreciate that. So just a final announcement before we go. This month we had 2 webinars, the one with Kim that we just finished, and one on mental health, because we also know that mental health is something that is really critical in a time like this, especially with people living with breast cancer and COVID-19. So next month is going to be Breast Cancer Awareness Month. So there's going to be a lot of activities around breast cancer everywhere. So whatever information that you get from us, from Susan J. Komen, from any other organization, try as much as you can to, whatever message you're trying to pass, try as much as you can to collaborate, partner, and ensure that you spread and share that news with them. We're going to have a couple of webinars for the month of October. We're going to also talk about COVID-19 a lot more in detail. We're going to talk about contact tracing, case investigations, because we really want to ensure that we contribute towards reducing or mitigating the COVID-19 spread. So these are some of the things that would happen. And then we'll talk a lot more also about breast cancer, because this is going to be a breast cancer month. So keep connected to us, keep your ears open. We're going to be sending out a lot of information around all of these activities. So thank you very much, everyone, for tuning in, for joining. If you have questions, I think this is a good time to ask questions before we quickly go off. So Kim, do you still have a little bit time? I know you're very busy and we want to jump into another meeting. Let me just quickly see if there's any questions so far in the chat session. Oh, okay. Kim says she has another meeting. All right. Okay. So thank you very much and take care. Bye, everyone.
Bye. Thank you. Thank you, Chris. I'm sorry. I did have to jump. I'm actually a little overbooked today. Yeah. But if there are questions and your organization collects them and you want to send them to me, I'm happy to respond in writing. I'm happy.
Awesome.
Okay,
yeah,
I'm sorry.
I couldn't definitely send them to you.
Yeah, all right. Absolutely. I'll do
Thank you very much for your time, Kim.
Thank you so much. Good to see you.
All right.
Bye-bye.
Okay, bye. Bye, everyone. Thank you for joining in, everyone, all of the participants. We appreciate you. And take care. Bye.
Okay.